number that we see? Should it be in multiples of MAC awake rather than MAC immobility?
I don't know at this point. I really don't know. We are all very familiar and comfortable with MAC. We are much less informed about MAC awake because much less studies have been done. And the studies are particularly difficult for MAC awake because it's very possible that the patient is awake during a procedure, but very comfortable and doesn't move spontaneously, but forgets about the whole event. So how can we tell whether the patient was conscious or not? In the forearm techniques, BIS monitoring didn't help, and EEG monitoring didn't help because they couldn't pick out the patients who were moving on instruction.
We have a question from Evan Karish. Should we be petitioning the anesthesia machine manufacturers to change the screen name of the monitor to FMAC?
It's more correct, absolutely.
Okay. All right. Well, we're a couple minutes behind, so I'm going to introduce our next speaker. Thank you very much, Dr. Wolf. You want to take your here, I'll put the computer over here.
Thank you.
So our next speaker is Jim Phillips from the Brigham and Women's Hospital. Jim is a professor of anesthesiology at Harvard. He earned 2 degrees in electrical engineering from Cornell, and his contributions to medicine include development of devices such as physiologic monitors and infusion pumps. And in the educational and research realms, Jim created GasMan, the topic of his talk today, as a computer-based simulator to teach clinicians about inhaled anesthetic pharmacokinetics. He's also published research using GasMan to analyze interesting clinical scenarios. It's important to note that Jim receives no financial benefit from distribution of GasMan as software, so it's a free download to all of you. Unfortunately, Jim won't be with us today, and we'll have his right. I think this is a pre-recorded presentation, so he's well within time at 20 minutes and 34 seconds, and he'll be available hopefully for questions at the end.
Inhalation Anesthesia Kinetics is the title of this talk. I'm glad to be here and glad to be here with you. Inhalation anesthesia kinetics is a complex subject with many subtleties, but we as clinical teachers owe it to our students and to provide them with the basics and give them tools to explore further. There are mental tools and there are physical tools. In clinical care, those tools are the vaporizer, gas flows, and monitors of anesthetic tension or partial pressure. Outside clinical care, they need something different. The mental tool is a model for anesthetic flow from vaporizer to brain. I will show you how GasMan is the physical tool that you can use for that mental model. We begin by thinking about the original article by Seymour Keddy in Anesthesiology in 1950. In that article, he looked at the physiological and physical factors governing the uptake of anesthetic gases by the body. He looked at the depth of anesthesia depends primarily upon the concentration or the partial pressure of a particular anesthetic in the brain. That anesthetic gases obey the simple physical laws of diffusion and solubility. He created an interesting mental model, and that is a bellows receiving a step change in drug concentration going into that bellows. And what we see is the model of the curve. We begin by looking at the wash-in to this bellows of anesthetic, and we see the concentration going up. Each little step is a breath. And what we're looking at now is lung wash-in. If we now make a hole in the bellows, over here, we see constant removal by arterial blood being produced, and that is generating a plateau in this curve. And then if we were able to put a box around this outflow and inflow from the lungs, we can actually capture the gas that was being breathed out or the gas that is coming back in the bloodstream. And it's going around in the circle and creating for us a tail of this alveolar tension curve. So that's venous return to the lungs producing that. Well, if we look at the curves that he then generated or drew for the various anesthetics of that time, we see that each one of them has those same characteristics. It has an initial rise, a pseudo plateau that you don't quite see, and then the tail of the curve continuing on out. The alveolar tension curve height is lowered by increasing blood solubility, and vice versa. Now, Ketty concluded that these few fundamental principles may help one in predicting or explaining what these physiologic and physical factors do in their various clinical associations. If I could build a model that replicated these curves, it would be the right model, and we could use this to learn better from. That was the thought that I had many years ago. And in 1980, I got a grant from the Apple Educational Foundation to write the program that I was going to call Gasman. I was going to write a workbook, and that got done a few years later by me. Addison Wesley then published that. It was called Gasman with a registered trademark, which we filed for and got. And through the years, I developed it in piece by piece with different authors helping me, doing some of the programming, and the rest I did myself. And we became a nonprofit corporation, a 501c3, in 2007. And by 2014, we had a free student edition that did isoflurane and nitrous oxide, and the professional edition, which was not free but not very expensive, added all the drugs we could think of between ether and xenon from solubility. The totally free professional edition worldwide was released in 2020, and that's been available to all of you and continues to be. We also began work on an open source program that we will release sometime in the future. Well, the Gasman workbook guides the student through the lessons of importance. And what we see is it begins with some an overview and getting started with Gasman, which is actually a user manual of about 4 or 5 pages. And then we learn the real kinetics of inhaled anesthetics. We understand a 1-compartment model. We understand when we have 2 compartments linked to each other. We then generate the alveolar tension curve in the simulation and identify that the plateau height and blood gas solubility are both interrelated. We then learn a little bit about overpressure to optimize the anesthesia, that is, to get the patient's blood level up to the desired level of anesthesia. We then learn that there's something called the high inspired concentration effect, a subtlety, but it was time to teach it in the chapters as they went along. And then we move on to low fresh gas flow. And then in chapter 10, we go to a fully closed circuit. And then in chapter 11, we look at one of the subtleties called the second gas effect. And then we move on to looking at patient wake up and see how that occurs and how we can control it. Then we look at modifications of patient size so we can have adults, children. We can, in fact, in Gasman, go from mice to large cows and do simulations for any animal in that entire range of body weight. We then have a chapter on analyzing costs, so we understand how to figure the cost of the anesthetic. And then we look at advanced features of Gasman, which I will not go into today. This is what Gasman looks like. It is a structure behavior model where the structure is a vaporizer going to a breathing circuit, going to the patient's alveoli or lungs, and then coming out in arterial blood and being carried to vessel-rich group, to muscle, and to fat, and then returning in venous blood back to the patient's lungs, from which it's either exhaled back into the breathing circuit or thrown away out the pop-off or APL valve. We also have here the fresh gas flow, controlling the relationship between the vaporizer setting and the breathing circuit. We have alveolar ventilation, then carrying the drug from the breathing circuit to the patient's lungs. And we have cardiac output, carrying it from the lungs into the arterial blood and going to the tissues. The tissue we are most interested in is the brain. The brain is located in a group which we call the vessel-rich group. And that vessel-rich group is all of the fast compartments of the body. And it also goes to muscle and fat. Now, it isn't just the brain that's anesthetized, it's the spinal cord as well, but that is in that same vessel-rich group. And the connections, again, are the fresh gas flow, alveolar ventilation, and cardiac output. We also see a clock ticking along, so we know how long the simulation's been running, and we can run it at any speed that we want. And we have the patient's uptake of anesthetic and the amount delivered from the vaporizer. So with the agent levels and partial pressure at the top, and the flow and carrier gas at the bottom. Anesthetic tension is the word we're going to use for the concentration of anesthetic. Concentration is fine to use when you're in the gas phase, but if anesthetic gets into tissues, it's partial pressure of anesthetic that counts. And it's partial pressure of anesthetic that equalizes across compartments when we wait long enough. It comes to full equality, whereas concentrations come to ratios of each other. We then look at the returning flow. The venous blood then comes back to the patient's lungs, and it complicates our thoughts and complicates our teaching of this subject. So again, we're going from vaporizer to breathing circuit to lungs and then to cardiac output. We have the timing and we have all of those other things. Our goal typically is getting the vessel-rich group up to 1 Mach or some fraction or multiple thereof. And the dotted line is at 1 Mach for each drug drawn on the diagram for us. If we wonder if Gasman has accuracy compared to real patients, we look at this publication by Bouillon and Schaefer many years ago, where they looked at data in another manuscript and identified that if they did the simulations that were the same that were in that paper, they in fact had Gasman and real patient identical over that whole range. The wash-in at the beginning of the case for the first 15 minutes, and then at the end of an anesthetic of 1 hour duration or 2 or 4 or 12 hours of duration, it then had the wash out of the anesthetic. It's going away at the end of the case, matching, again, Gasman being very close to that patient data. Bigger sets of patient data have been published. Professor Ravi Shankar from India and his team, in fact, showed the difference between Gasman point by point compared to patients with his drug was isoflurane, and has been done with other drugs by other people, but not published as well. We look at the recent paper by Dr. DeWolf, who's here with us today, and see that he was able to demonstrate Gasman having good validation as far as matching patient data, again, with more recent drugs. We've also looked at Gasman, well, we haven't, others have with our help a little bit with it, with obese patients, for example, and Jonas Weber did that and published that in 2021, and also looked at other things like variations in cardiac output and alveolar ventilation, and again, demonstrated that they were well represented within Gasman. Now, in the interest of time, I'm not going to do the simulations today, but we're going to look at the alveolar tension curve and understand that it is the response to a step change in inspired concentration. We're going to show the components, that initial rise, plateau, knee, and tail of the curve that I talked about before. And this is exactly the way those curves look if we create them. So here in the upper left-hand corner where my arrow is pointing, we have the patient where we have no cardiac output, and we have just lung wash-in of anesthetic, and we see the alveolar tension goes up and up and up and up in an exponential curve. If we then add to that cardiac output from the patient, that is taking drug away from the patient's lungs, but not letting it come back, what we get is a flat plateau of that curve. And then when we do the simulation with venous return being normal, we get a curve that looks like this. If I then in Gasman click what's called the overlay button, where I overlay all of the simulations that we have done, we see in this overlay graph, we see the initial rise would have continued. The plateau is formed here, and the tail of that curve comes right from the base of where those all started. We can simulate various anesthetics. This is just a simulation of isoflurane, sevoflurane, desflurane, and xenon, showing that, yes, in fact, solubility does just what we had learned from what Ketty had said, which is the high solubility drug, isoflurane, has a much lower plateau height and a lower curve throughout. Well, those are the theoretical things that we can teach and learn with Gasman. Let's look at some clinical simulations where we use Gasman to simulate things that we might want to do in our patients in the operating room. In this case, we've got simulations that were done by Eager and Schaefer, where they did hundreds of Gasman simulations in order to understand context-sensitive decrement times of these various agents. They were looking at isoflurane, sevoflurane, and desflurane, and what they showed was after an anesthetic whose duration is shown here on the time axis, we're looking now at the amount of time until the anesthetic comes down by 80%, by 88%, by 90%, by 92%, and 95%. And what they were able to show was that once you are looking for an 88% fall in the anesthetic level, if the anesthetic has gone on more than about 90 minutes, that wake-up time, or that down by 88% time, goes dramatically up. If we look at a desire to get the level down even lower, that is 88% down, now 90% down, we see that isoflurane is way off the charts. Sevoflurane is starting to take a long time as well when we've given a long anesthetic. And that if we want to get down by 92%, sevoflurane is now taking a long time, many minutes after I shouldn't say that. I should say 50 minutes after an anesthetic of 200 minutes of duration. And finally, when we're shooting for a 95% decrement, that is the patient at 5% of wherever we had him during that case, we see that all of our drugs start to not do quite so well. And desflurane, even by the time you get up to 90 minutes, has a 25-minute wake up to get all the way down by 95%. So that's how we can demonstrate complicated things like context-sensitive decrement times with computer simulation, something that we never could do in patients, but always wanted to know the answer to. Here's an example where I was using low fresh gas flow anesthesia and asking the question with sevoflurane, how should you anesthetize patients if you want to get them asleep reasonably fast, but you don't want to be too wasteful? So here, what I've done is simulations with a fresh gas flow of 2 liters a minute, of 1 liter per minute, 2 liters per minute, 3 liters per minute, 4 liters per minute, and 5 liters per minute. And what we're looking at now is vessel-rich group over MAC. So we read this overlay as a sentence, show VRG over MAC, so that when the vessel-rich group is getting up to MAC, that's 1 there, that's the time to get a patient anesthetized reasonably for an incision, but if we want to get the patient deep enough for placing an endotracheal tube, for example, we'd like to be a little bit higher, probably at 1.3 Mac. And what we see is if we used a fresh gas, and all of these are done with the sevoflurane vaporizer at the top. If we wanted to get the patient up to that 1.3 Mac, and we're using a fresh gas flow of 1 liter a minute, this is going to take 12 minutes. If we go to a 2-liter fresh gas flow, we've dropped this down to 7 minutes. But when we go up to a 3-liter fresh gas flow, now we've got it down to 4 minutes. And when we go higher than 3 liters a minute to 4 liters and 5 liters a minute, we gain a few seconds in that anesthesia time, and that's not worth spending all that extra money on. So we can say that a low fresh gas flow induction with sevoflurane should never be done at above 3 liters a minute, because that's simply too wasteful. One might ask, can I use drugs like sevoflurane alone for general anesthesia or cystoscopy or a procedure like that? And the answer is yes, we can do what's called a vital capacity induction for cases of that sort, where we have the patient take 1 deep breath of sevoflurane, 8%, and that's all it takes. And here's Gasman simulation overlaid on top of a real patient data. That is, the agent monitor is this orange graph, and that's the graph behind it, and the orange breath by breath motions there. And this is inspired sevoflurane. Patient has taken the giant breath and inspired has come up in that breath, because that's the way the anesthesia machine had filled it. Alveolar has come up here too. This is 1, 2, 3, 4% sevoflurane right away, and is rapidly getting up to 7% sevoflurane. Meanwhile, the vessel-rich group is coming up to about 1, 2, 3, 4%. We're at 2 Mac right now. Now, you might think that's very deep, but it's just the right level to intubate a patient. And then once we've got that patient intubated and we want to get the anesthetic back down to something very safe, we can simply turn off the vaporizer completely with a high fresh gas flow, get inspired down to 0, well, not quite to 0, but get it very low, get alveolar very low, and have the vessel-rich group come right back down to that 1 Mac level, and then carry the patient for as long as we want at that constant depth of anesthesia. So simulation gives us answers to clinical questions, and we can ask some theoretical things, such as if a patient hypoventilates after extubation, can he become reanesthetized? And Dr. Leeson and a student and I did that and published it in Anesthesia and Analgesia in 2014. And what we found was this now is the fall in alveolar level of anesthetic that we would expect in those patients. But if that patient hypoventilated, instead of it being the solid line, it was the dotted line that came back up again. So the patient had reached Mac awake, 0.33 of 1 Mac, had reached that Mac awake level, but by hypoventilating, yes, they would get deeper again in each of these situations. And it reminds us that after awakening, we need to keep the patient breathing. And this is after 4 hours of anesthesia with all of these. If a patient becomes reanesthetized after extubation, where does the drug come from? Well, muscle is really the answer. Muscle has a time constant of 1.5 to 2 hours, and it has a chance to fill up during an anesthetic. And at the end of 4 hours, muscle is saturated with anesthetic. And I was taught that it was fat that produces slow wake up. And the question is that true? And the answer is, it really isn't true. Patients wake up again when the vessel-rich group gets to 0.33 Mac typically. And fat gets up to 0.33 Mac 17 hours into an anesthetic with sevoflurane and 10 hours into an anesthetic for desflurane. So if we typically do not anesthetize patients for that long. So the fat has never gotten to above MAC awake. Therefore, the fat is actually contributing to wake up, not contributing to keep the patient asleep. We see that here in the graphs that are a little difficult to see due to the lighting, but what we see is a line here at MAC awake and the amount of time it has taken the fat to get up to that level. This was that 10 hours with desflurane, and this is the 17 hours with sevoflurane. And if we now take a look not at fat, but take a look at muscle, muscle is this red line, is this brown line. Muscle has gotten up to MAC awake in 1 hour with sevoflurane and has gotten there in 45 minutes with desflurane. So it is muscle that is the place that the anesthetic is up to that full MAC level. And when anesthetic comes back from there, that's what will keep your patient awake. That was what will get your patient back to sleep again when you didn't want it at the end of surgery. So we can use computer simulation to answer many questions. And each of these answers is based on sound theory and sound mathematics, and each is easy to use in the operating room every day. We can apply these concepts once we understand them. And by using computer simulation to answer many questions like this, we can become better anesthesiologists. We can learn something like sevoflurane safer than halothane if the patient is hyperventilated. Yes, the patient is 3.5 times safer with sevoflurane. Let me show you why. This is the alveolar tension curve of wash-in with halothane, isoflurane, and sevoflurane and desflurane. If we hyperventilated a patient, we would move this curve way up here. So in the patient who's receiving halothane and is hyperventilated, the anesthetic level gets much higher. Because halothane is so soluble, we have to have the vaporizer up very high, in fact, and if we continue ventilating the patient or hyperventilate the patient, we end up with an overdose. With sevoflurane, hyperventilation does not bring him much deeper than he was before. And in fact, if we look at this graph, again, all of these have been done with gas mask. If we look at a patient breathing spontaneously with halothane, this is the natural course of the alveolar concentration, alveolar tension of anesthetic, and it comes up to that 1 MAC-ish level very nicely. If we ventilate them constantly at their own normal ventilation, rather than letting their ventilation fall like it does naturally, we get them a little bit too deep. But again, if we hyperventilate them, we get them in trouble. And we know that halothane was withdrawn from the market years ago because of the cardiac arrests in pediatric patients who were probably all hyperventilated. And this explains why that was so dangerous. We're running a little bit low on time, so we can do things like looking at patient size scaling, and we can identify that the 4-kilogram patient versus the 70-kilogram patient, yes, they have a difference in speed of anesthetization. So the time is a little bit different, not a little bit different there. It is significantly different there. But the plateau height, that is the height that expired gets to for constant inspired, is the same in the pediatric patient as in an adult if they have, in fact, the same ratio of cardiac output to ventilation. So small patients get just as deep, but they get there faster. Another interesting concept is the high concentration effect. When breathing nitrous oxide at a high concentration, you get up to a much relatively higher level than you do breathing the same nitrous oxide at a low concentration. In each case, we're now looking at the expired compared to the inspired. So this is what we call the high concentration effect, usually called the concentration effect, but it should have been called the high concentration effect because it is only at very high concentrations that this happens. Also, another topic of this sort is the second gas effect. This is the curves for isoflurane when we're given without nitrous oxide or with nitrous oxide. And in this situation, it definitely causes an increased speed of anesthetization. Well, that's all we have time for today. If you would like to learn more, if you, with your internet browser, search for Inhalation Anesthesia Gas Man, you will get to the program for downloading, which is totally free. You will get to a video that teaches how to understand this in a way a little bit better than I gave it today, but it's a way I gave it on the day that we recorded that lecture. And that was sponsored by GE Healthcare, by the way. And my doing of it was sponsored. And also an interview from the Society for Education and Anesthesia on the development and evolution of gas man. Thank you.
See you up there. Are there any questions? We are running a little bit behind. We have one. I hope he's in an Uber. Yeah.
Hi, James. This is a fantastic presentation. Thank you. So, a couple of questions. One is so we have several anesthesia. Should we be concerned information to self second question is sensitivity for exposure. To estimate sensitivity.
Yeah.
Jim, can you hear us?
We can't hear Jim. Jim, I think I don't know if you're muted. No. All right. I think we're going to have to, thank you, Jim. Take care. Okay, let's move on. So our next speaker is also joining us remotely. It's Dr. Nassiri, who you can see in the second row of the second column over there on our Zoom screen.
I want to make sure for audience.
Okay.
Just ask her to say hello.
So can you say hello so we can make sure we can hear you?
Hi, everyone. Can you hear
Great,
me?
thank you. So Somana Nassiri is a PhD and MSc. She's a new professor, assistant professor at the Emory School of Medicine in the Department of Biomedical Informatics and Neurology. She completed her bachelor's and master's degrees in electrical engineering, moved to Emory to pursue a PhD in biomedical informatics under the supervision of Dr. Gary Clifford. In 2020, she graduated with an outstanding PhD thesis award, moved to Boston, and undertook postdoctoral training at Harvard Medical School under the mentorship of Professor Brandon Westover. And she was promoted to faculty at HMS in the MGH Department of Neurology, where she led a study called the Complete AI Sleep Report.